great. I saw Pam do a double step on the way in. That was a big improvement, Pam. Although Gus is still underperforming, I'm concerned. Okay, finding your seats, please, people. I'm sure you've enjoyed that fabulous morning tea, and there certainly was a lot of networking going on out there. That is one of the key goals of this conference, is for people to make new networks, find out who's doing what, maybe start to think about some collaboration moving forward. And on that note, if you know an organisation that's not here or an individual that's not here, and there obviously is many, we would love you to jot it down. We've put it up, our idea board up over there, because the goal of Remote Australians Matter is to bring everyone along that wants to be on the ride. So if you could put down who else they need to be talking to, that would be fabulous. Now, before we kick off with Cheryl's presentation about the third existing model that's working really well, and in fact beyond really well, it's an internationally recognised success story, I've got some comments here from the crew that are online today. So Rosemary Young said, first, the people and communities of remote Australia need to be valued as an intrinsic part of the nation, its economy and its well-being. Helen Webster said, get the Batuta Advocate to visit country towns. That can be a double-edged sword, but I'm sure you can put that on the comms plan, Jude. Helen Webster also said, great proposal to get communities themselves to be able to manage their own funding and solutions. And Charles Older said, this is what I do after founding the charity Rural Aid. So it's fantastic to have those people who couldn't make it joining online, and please keep up the comments and interaction, and when we go and do groups later, we look forward to them being involved still. So, as I mentioned, we've now got Cheryl coming to talk to us about the remote model of healthcare they have here at Quatsich in Charleville. So she's been the CEO at the Charleville and Western Areas Aboriginal and Torres Strait Islander Community Health for 23 years. Wow. When we've talked about longevity being an issue in remote communities and burnout, to have done anything for 3 to 5 years is considered a long time. So 23 years, Cheryl, that's amazing. We can all learn something from that too. So Cheryl is a strong Aboriginal Bidjara woman who's also Torres Strait South Sea descent on her maternal side. She's an experienced director, having held roles in a range of health and social services board, including currently sitting on the board of QAIHC, and I'm sure there's a way of pronouncing that, Quake maybe, and Western Queensland PHN and NACCHO. She's passionate about meeting the cultural needs of Aboriginal and Torres Strait Islander people and committed to delivering quality, comprehensive primary health care that is essential to ensure improved life expectancy. Sounds like a perfect combination, and we know that you're someone who's recognised across the country for the work you've done, Cheryl, so we're really privileged to have you here today. Let's welcome Cheryl on the stage to share the Quatsich story.
Thank you, Wendy, for the introduction. Yeah, I've been here for a while. I didn't say much in the welcome last night, but I might give you a little bit of spiel about myself first. I know I've only got a short time. I was actually born in Augathella, and this is something that I would like everyone to think about, well, I know we've got the voice referendum coming up and the voting on the 14th of October. I know that some of you, we've had information thrown at us, misinformation, facts, etc. But it's in your own mind that you make your own decision. But I was born in 1961. Now, you all know that the 1967 referendum. So guess what? Here I stand before, but I was counted as a cattle in 1961. Something to think about. As I said, I have my mother raised 9 kids by herself. My father died 39, 40-year-old. Now, our life expectancy wasn't paid. I've Marfan's, which is, eyesight, being tall, heart problems, whatever. There are people worse off than me. So where we are today is through my passion to make sure our mob live longer. This is terrible.
It's terrible. We'll all be crying with you because of your passion.
Yeah. I raised 2 daughters with the help of my family. I went to university. I was actually going to study to be a teacher. But I got homesick, come home. Strangest thing, for Aboriginal people, we don't like being away from home. It's true, and so does other people. I couldn't become a teacher because I wouldn't sing. We had to, when you want to work as a teacher, you got to sing with little kids and, your students. And you wouldn't believe it, I failed my first aid. Because I passed out when they started talking about blood, but here I am, the CEO of a health service. And my doctor down there, Julia, and nurses, and everyone knows as soon as that needle come, I'm an Aboriginal, I'm dark, but I think I'm the fairest in the health service. So that's a little bit of story, but we talk about our hardships and our challenges, but being involved in this health service and my capacity to meet and influence and work with other people, that's been an advantage for me. So, am I moving the gadget or up there? Oh, is that up there on the... Yep, okay. So QATSIC is an Aboriginal community controlled health organisation providing culturally safe, culturally secure, comprehensive primary health care in remote, rural and regional geographical catchments in Queensland. QATSIC has a base here in Charleville. We have outreach. Our second main office clinic is in Roma, and we also have offices in Mitchell and Quilpie, and we also service Windora under our primary healthcare model. However, we're actually funded also through the we're co-commissioned. We're commissioned by the Queensland PHN, which I'm a director on, and it's not about nepotism or pecuniary interest. However, we support the Channel Country right out to Baduri, Batuta, Birdsville, and up to Winton, back down with the Central West, right down that line. We provide a Nukumara Alliance, which is the other 4 archos, which is Hullamulla Primary Healthcare, Gundair in the St George region, and Gidgee Health, Mount Isa. We come together to form an alliance to make sure our chronic disease management is a collaborative event and that we get better outcomes for our people that are managing their chronic disease. Our vision... Oh no, I've gotten too far. Our vision is around a generation. It's for Aboriginal and Torres Strait Islander people to live in inclusive communities that deliver equality and health, well-being and life expectancy outcomes. We were established in 1994, so our 30 years comes up next year in April. We first became off in, how do I go back again? Yeah, opposite, That's right. Go back. No. Stuff like that. Anyhow, we started off as a taxi service because one of the things we found that Aboriginal and Torres Strait Islander people were dying at an earlier rate. We all know that. 1 minute was, this, they say there's a 17-year life expectancy gap, now we're down to 10 or whatever. But the fact remains, Aboriginal people here in Charleville, alone in southwest, were dying earlier. Now we have people living 60, 80, 90. My mother's 81. We've had people here that lived here till about they're 94. We have board members that have only resigned off our board at 80 odd, 90 odd, and passed away, bless them. But what remains to be seen, people say Aboriginal community control saved our life. Now we have about 150, 145 ACHOs right across Australia, and I'm actually an ACHO appointed director very recently. But I've been on there on and off over 22 years. I've got to get somewhere up there. And you think about it, ACHOs have been a success story in closing the gap for Aboriginal and Torres Strait Islander people. And not only that, I'm here to promote First Nations people. But one of the things that government or everyone don't understand, that a lot of non-Indigenous people access our service in rural remote, because we are the lead providers. We're the only providers sometimes, because the acute system is sometimes overloaded, and they're there to do their job as an acute tertiary system. And the reason why we're a success is because of the strength of our community. Ownership, it's owned by the community, and consistency of good governance and local decision making. So we've talked about all of that, the panels, in the last night, today. So in the 30 years we've gone from we built the trust of our community through a population health model. We went from a taxi service, getting everyone to the hospital, getting them immunised through the various stakeholders and the service providers around town. But then the board reckoned, well, we can do some of this ourselves. So we started doing population health. Now, government took that away, population health. But we continue to do that. We build the trust. We used to have events, big events at the race course, here, across the road, the showground. We would do NAIDOC activities, whole of community events. And first, people used to come with everyone says drug and alcohol is a problem. We still do, it is. But one of the ways that we learnt, and they talk about health literacy, but we do it our own way. People used to come over, we used to have our big do's over the road, and I'd pay respects to John Maris. He's still been a member, he's still a board member, and my staff here today. And one of the things that people used to say, well, is alcohol allowed? And I said, no, you can't, brother. Yeah, well, you don't know. We can put alcohol in the boot of our car. And I said, you know what? I said, I'll be meeting you at the gate. I'll open every boot and every grog carton I see, I'll smash it right there and then. And they reckon you can't do that. I said, try me. You want to come to any of our functions? This is what I'll do. So guess what? Over that span of 10 years, we have now run programs with no alcohol and drugs involved. They turn up, they're happy to participate. From there, they go to our clinics, our social and emotional wellbeing programs, everything. And alcohol is not involved. So when you talk alcohol, and you do it on the mainstream side, but the way you've got to do it is be innovative, and it's the community's decision, and when they accept it and they learn it and they embrace it. We then went to, over the next 5 years, we've been through floods and everything, but I'll pay respects to Dr. Julia Fielding. I wanted to have a doctor. So we had a yarn, and she said, well, I'll come down and do a fee for service. So we started off as a fee for service. Then they said, we'll never get AGPAL accredited. And I said, well, I'll beg to differ. through having Julia and her, how her expertise and knowledge supported us to grow and become further advanced each year as we became bigger and better. And we built new buildings. I lobbied hard to get better buildings, and like Sarah said, it's hard work, but you just got to be smarter how you go about doing it, your influences and your contacts and your partnerships. Our state body, Quake, assisted a lot, getting me the data and the facts. And this is where we are today. We've got a beautiful building, if you haven't seen it, down there on 94 Edward Street. We had to raise it up for the flood. And I'm now currently got a $1.4 million project to add a single-storey, 9-room building to in addition. And starting with Dr. Julia as a fee-for-service, build her up, she left us, she come back, she's still with us, probably be there when we're gone. However, we've been able to maintain a lot of doctors coming through our services. One particular doctor, he's just retired. He actually been to a lot of living around, working around Australia. By the time he landed with Kotsik, he said, and I'm not bragging, I'm just saying, he said, this is one of the best model of care and working conditions that I've been a part of. He was only there for a couple of years, Elaine, was that right? Now he was there nearly 7 years. Now we talk about some of the solutions. One of the things that we did with some of our doctors now when they come out, they got to be immersed in our model of care. If they don't fit into our model of care, we politely say, look, you're not going to fit, you'll have to get back on the plane. We want someone that's going to move and work with our community, because it's about access for our mob and the trust our mob have in our GP services and our clinical. And not only that, our wraparound services. But we've immersed them in our, because I suppose one of the advantages too, I'm a Bidger traditional owner, and we have a property 3.5 hours away, and it's a beautiful country, and it's got all our local, it's got Bidger artefacts, cultural sites, and we do a lot of programs up there. We actually immerse our GPs in the cultural immersion and the history of our areas that they're going to work in, so they understand our mob, our culture, and how we like to live and, breathe. So during they might work for 2 weeks, 3 weeks, 4 weeks, whatever. In that time, we'd like to take them up. We take them up the first time, then they make their own trips up there. They're welcome to go. We make arrangements with the station manager. But we try to immerse that cultural immersion of cultural history, knowledge, and bring out and make sure our doctors. With the GP registrar training, we were fortunate enough, they come out and they do their training at Kotsik. One of them has actually made a commitment 2 years ago. He comes back to us in 2024, next year. A young fella that we took him out to the community, he met people, he made his own friends. In that time, he even came back for our Melbourne Cup with the council. We have a gazetted day in Melbourne Cup. Please don't ring us, anyone, that day. Not even in the morning. But he brought his family back here to Charleville and said, this is where I'm going to be, working and living. And he's a young registrar that's finished his training. He's coming back here to Charleville, to Kotsik. And I must say, in all that years that we've trained health workers, because we're an Aboriginal health worker-led organisation. Our health practitioners, we don't have RNs. I don't have RNs. We've had an RN working with us, a couple of RNs working with us over time, and we appreciated their contribution. But they also learned off us too. Because when you're in the mainstream working in a hospital setting, it's totally different working in Aboriginal community control. So you really think about it, our model's been going for 50 years, and what I hear everyone saying here is absolutely right. This is what we've got to do in the real remote setting, because Aboriginal community control have been doing it. Well, we've been doing it here in the southwest for 30 years. And our model of care, which is up there at the moment, tells the story of how we actually do it. Our workforce, we're actually all multi-skilled. When I did have my licence, I remember the community, they used to always say, because they thought we were going to be the free taxi in town. And they used to say, oh, can we get a doctor? We need to go and pretend to go to the chemist and get their medicine. But when we get there and they said, no, I want to go and get a haircut. I said, oh, yeah. So one day the receptionist says, there's no transport officers on, and they said to me, oh, someone needs to be picked up. I said, rightio, because I knew exactly what was going to happen. I drove up to the house. It was my cousin's house as well. He reckoned, I said, where are you going, cuz? He reckoned, oh, just downtown. I said, yeah. And I spun the wheels and took off. I said, well, walk or ring it. And he rings the office and says to Vicky, the reception at the time, why did you send the Cheryl up here? You shouldn't have done that, But they're the things you've got to do in a small community. And if patients never used to come to our doctors, and they said, Cheryl, your uncle's not coming. Well, I'd drive down to where uncle is, and he's sitting around with the boys and, having charge. And I said, get in this car, you're going to see the doctor. He said, no, make another appointment next week. I said, no, do it now, or I'll drag you all the way in. So my uncle, these are the things I could do as a CEO, but because I'm a TO and this is my community. But I would say, there won't be no next week, you could be buried next week. So you get in this car and we'll go and see the doctor. They would then come, get their medication, and whatever, and they're on the mend. But some drastic things that I've had to do after 20 odd years. But basically all of us are multi-skilled within the organisation. Because of workforce issues, I've had to combine some of our positions and pay accordingly. And our funding is not that much. We might have millions, but our Medicare, through Medicare bulk billing, everyone says you can make money, but at the end of the day, it doesn't. The community needs are more and more and more. The holistic approach, we talked about that on the Friday, last night. As an Aboriginal Community Control, that is our main area of expertise that we do. We provide the holistic approach. We don't just deal with the mother and dad, we deal with the kids, the whole family, the extended family, all. If they need to be COVID immunised, we say you do one, you do the lot. We have a bus through the NIA under our IAS, the Indigenous Advanced Schooling Program. We go around and pick up all the kids because we knew that there was truancy in the schools. I said to the staff, go around, pick all the families and make sure the kids go to school. However, by picking the kids up and taking them to school, their whole family had to have a health check so that we could pick up anything that would have been, that needed to be managed or the family needed to be managed. So we just we didn't just concentrate on the kid. They had to be immunised, they had to have the health checks, care plans if required, and all the support mechanism around them. But for them to get that bus lift, get to school by being picked up. And they loved it. We do morning, we help the schools by giving brekkie at the schools, at all the schools here in town. Good governance. As I said, I've got a long-standing board. At the time I've been there, I've had a long-standing board members. And as I said, Johnny Maris is one of them, and the rest. And we're an ageing board and we've been trying to recruit younger ones, which we have in the last couple of AGMs, and we are got to do governance training with them. But having a good board that understands and we're all on the same page of where we're going and what direction, and improving our life expectancy for our people and have better access to primary health care and all the allied health services and the wraparound that they need. And we also have the option of traditional medicine. We run social emotional wellbeing dues where we bring in spiritual healers. We bring in counselling support by other that have that traditional method. We use art therapy. So we use a lot of methods around traditional healing. The stuff there that I've talked about, that's a lot of the services that we provide in our wraparound services. We start with our clinical model, we use programs, we use our partnerships with, for us to achieve this, I'll also recognise all our partners. You know, we can't do it on our own. But one of the things our partners and everyone needs to recognise that the model of care we provide is effective, efficient, and is keeping our people alive. We need that respect and investment to ensure that we can do it better and make their job easier when they turn up into the acute system, and which we've started to work. One of the things that Queensland is fortunate, and it's a major reform in my lifetime, and probably I won't ever see it, you know, the fruits of it until a long time, but the next generation probably will. The health equity legislation has been passed, and now all the HHSs, the 16 HHSs across Queensland, have had to do a strategic plan around health equity. And then from that, with the consultation with everyone, Aboriginal and Torres Strait Islander people, ACHOs, traditional owners, community people, they've now come up with a plan. One would hope that they're genuine in actually implementing that plan and putting the investment where it should be. We launched the Southwest HHS in Colomulla, and Karen, the Chair, and the CE have made a commitment to ensuring that we work on that implementation plan to get success. It's going to be a lot of work, a lot of changes to the systems, and we know there's going to be barriers because people with their mindsets and the way that they work, it's not within their scope. But they've got to learn that if they want to make this plan a success, well, we need to all work together and respect each other's expertise, professionalism, and knowledge, and the staff, each person, and each skills that our people bring. Everyone brings to that table to make sure the patient's journey and outcome is beneficial to them. So we have our clinical services. As I said, we have probably sometimes up to between 4 and 6 doctors. They're all fly in, fly out, but until we get... but they're constant. They're not ones that fly in, fly out, and I know June spoke about it, but we have people that come for us, been coming fly in, fly out for years. And what that says, the continuity that we can give our community, whether it's Aboriginal or non-Indigenous, is that they can make an appointment to see that doctor they saw a week ago or a month ago. They just got to be patient to see that doctor. And so the continuity of our 6 doctors, 4 to 6 doctors, or how many, is that right, Lane? Could be more, eh? Or less on a day. That's when we'll shut down, for sure, no. But the continuity we provided with our fly in, fly out, because as I said, how we keep them here is the cultural immersion, the community immersion, and making them feel welcome, and making sure that their family's included in all of our activities. And I must acknowledge our Aboriginal health workers. We're getting short, very short on that, but there's other barriers around that too. You know, all this voluntary blue cards, criminal history checks, they do impact on us in recruitment, and that's across the board. But they are a wonderful, they lead that clinic for the GPs. They make the GP role a lot easier. They know the clients, they can talk to them, and we have our senior Aboriginal senior health workers, and they do a fantastic job in making sure everyone is inclusive in our community, in our health service. We have as I said, the chronic disease team, the Nukumara Alliance. I've spoken about that. It's 4 AMSs come together to talk about how do we follow up and make sure that we... Is it nearly time? Oh, shit. But Nukumara Alliance, you can read about that somewhere on our web. But one of the things I must say, the Western Queensland PHN funds that. They commission. Western Queensland, because there's a broad range of directors on there, and as I said, I'm one of the directors. But we commission the ACHOs to deliver on Aboriginal and Torres Strait Islander health. And we get outcomes. For the population that we had, I think it was 14,000 Aboriginal in the patch from the Gulf, Mount Isa, right down to St George, Colomulla, us. And that takes in the Channel Country everywhere. We serviced with $1 million, we serviced over 2,000 clients with chronic disease, given that and look, ITC is around, that we support the PTSS model. The PTS is there for everyone, but there's always gaps. And Aboriginal and Torres Strait Islander people wouldn't access their health appointments away because they didn't have the money. And so we then supported them. We also looked after them, making sure they had their CPAP machines if they've been died, because they won't go and buy it. And that's why we're living longer, you know, because all the support we can give them to manage their chronic disease through the Nukumara Alliance. However, we did a evaluation of that Nukumara, the Western Queensland PHN, and what we found, for every dollar we spent, we saved the hospital system $4. So, and keeping them out of hospital. I basically talked about our model. So really the challenges that I want to leave with you that we find as an Aboriginal health service is that health financing and funding, which we've actually talked about. Generally investing funding in evidence-based outcomes. The rural remote organisations need to have core funding that is reflected of higher cost in delivering care, which we've stated before, retaining workforce, and must provide sustainable security for population growth, health planning and community needs assessment. Rural remote funding is tightly prescribed to our services and does not cover the increased cost to maintain essential administration levels, number of accreditations, operational management and infrastructure costs that allow the service to operate efficiently and effectively. Our workforce, we've talked about our workforce, and we need to grow our own. And I must commend the Southern Queensland Rural Health in doing that. We started that project. Our nurses are trained at home. ARCHO is funded to provide increased access to culturally safe and secure primary health care and for Aboriginal and Torres Strait Islander people. But as I said, we're in a catch-22 with bulk billing. Policy requires doors to be open to everyone in servicing the whole community, often with only IHAP supplementary funds. So what it's saying is we get a grant from IHAP, from the funding body, but we're only supposed to service Aboriginal and Torres Strait Islander people. Then they say, how come your numbers got mainstream, have gone up more than Aboriginal? Well, hang on, you're a Medicare bulk billing, we've got to open our doors to everyone. So a catch-22, and until that policy changes, we're going to be disadvantaged. And we have a waiting list. We talk about all the issues around here the last day and night, you know. We've got to change policy so that we can actually deliver better outcomes. So one of the things about acute primary versus remote and regional Queenslanders have historically and traditionally engaged in holistic primary healthcare with their GP services. Today, the majority of care is acute presentation management, increasing presentation, disempowering the patient, consumer, and by default, reducing self-management. So you can think about, so it's better to integrate care. So we undervalue, under-recognise the knowledge and expertise we hold. Do not value us as a crucial equal partner in delivering services that are culturally safe and holistic. I'll go straight to the solution. For us living in a remote, rural and regional area, we must always aspire to improving our health and wellbeing services. And we know we can provide a good gold standard of care to all people in our remote, rural and regional communities. But all ARCHOs across Australia try to provide that gold standard of care. And we're talking about minimum health standards here as a remote Australian matter, you know, this conference. But I'll challenge everyone here. ARCHOs provide that gold standard, but why, when we go to a mainstream institution, hospital or anywhere else, that standard drops? It drops down to a bronze level. Why is that happening? Especially for First Nations people. And we need to change that because all rural remote people are entitled to a gold standard of healthcare.
Thank you so much, Cheryl. That was beautiful. You know, we were talking about, and in the earlier session, Nikki brought up we need to connect with heart. That was the most beautiful example of connecting with heart. And gosh, I'm going to be like quoting you guys forever. It's like I've been writing everything down. No data without stories, and no stories without data. And the stories bring the heart that connect with other people. And so that was, we're all left with a very clear understanding about why Cheryl is motivated to still be there 23 years later. And I mean, she's disappeared because she wouldn't want the praise, but you know, she talked about, like she kept saying, you've all been talking about this, about the continuity of care and that holistic approach and investing in training. She talked about cultural immersion, the models owned by the community with that good governance and decisions making and true collaborative model. The thing that I observed from watching Cheryl today was the added layer of leadership and courage and determination to create change even when it's really hard. So that was a great presentation about a model, but also an insight into the motivation to create real change for her people. So now we're going to go into the slightly messy bit, but this is all about you now, people, all about you. We're going into the idea marketplace session. So the purpose of this is for you guys to decide what do you want to work on this afternoon in your groups. What are the topics that this conference should work on to create the actions and advocacy for Remote Australian Matters going forward? So we haven't made the topics up, we haven't come to you with them because this room needs to decide what you want to work on this afternoon. So how this is going to look is we're going to divide you all into 10 groups, and so it's going to be a little bit Brown's cowy for a moment, but you've all been there. So there's going to be 10 groups in the room, and each group is going to have a designated speaker. So most of these people know that they're being delegated. Some it's a little surprise, but if I call your name, I'll get you to move to one of the tables. The tables all have numbers on them. So Rosie Clement, can you go to table 1? Gus, can you go to table 2, which is just there? Stan to table 3, please. Stuart Mackenzie to table 4. Peter Thompson to table 5. Pam Jackson to table 6. Stan, you're table 3, yep. Claire Britton, table 7. Carol Abel, table 8. John Maris, table 9. And Gillian Fennell, table 10. You were the surprise, Jill. So those guys are moving to the table because they're not going to get a number. The rest of you are all going to be handed a random number, and whatever the number says... Now, guys, can I just ask that we listen? Ladies, can you stop for a minute? Because I know that if people don't listen, this will take way longer. So this is... You're all going to get handed a bit of paper with a number. You look at that number and then you take your chair and your things, probably, if you don't mind, or you can leave them there, but take your chair and your number and move to that table because that's the group you're working in. When you get to that table, we're going to give you 2 big bits of butcher's paper and pens, because we expect in that big long table you'll probably naturally form 2 groups. And you're going to brainstorm, well, you can do it in one group if you like, but brainstorm. And then we're going to get you to come together and choose the 3 things you want to share with the whole group as topics. But the first bit of the process is you all, as a group, dump every idea down of what you think are the key topics that deserve action or advocacy by Remote Australia Matters. That's step 1. And that's all you're worrying about right now. So you're going to get a number, you're going to pick up your chair and move to that group. And then you're going to brainstorm what are the topics, potential topics for advocacy or action. Once we get going, after a little while, you will hear an alarm of some sort over this. That's when you stop and look at me. I used to be a teacher and I'll be going, I can see you, or I might go shoulders, heads, until you pay attention. Yes? Yeah, 1, 2, 3, eyes on me. All right, so get your number, get your chair, you're moving to a group and you're going to brainstorm all the ideas for RAMs going forward. Yes. What's that? Oh. The numbers are in Nico on the end of the tables. Starts at 1 and 2 up the front, goes to 9 and 10 down the back. Sorry to interrupt all the conversation because I know that you've really got going in some of your groups now. Remembering that you're choosing the key issues that you want groups to work on, finding solutions for or actions for RAMs going forward. In your group, can you identify the 3 top issues to be solved, worked on this afternoon? And they've probably got to be drawn down to a couple of words. So like workforce, for example, rather than big long sentences. So off you go. You've got 5 minutes to choose your top 3 topics. How are we going? Can you put your hand up? Can you put your hand up if your group has not got its 3 priorities yet? Okay, hurry up. Stan, you're underperforming. Sorry? Excellent, thank you. Okay, that's great. Excellent. Yes, we can start with number 1. Yeah. And we'll, yes. Yes, I'll get you to choose. Okay. The time is ticking. One more. There's always one, isn't there? So for the rest of you who have chosen your 3, what we're going to do is the leader of your group is going to stand up and read out your 3 topics. So we'll do this one group at a time. We'll then record them on the whiteboard. And then before you go to lunch, everyone will get to use the Mentimeter code and vote for the topics for this afternoon. So I'm just going to wait because I don't want anyone speaking until everyone is ready. Okay, hands up if you're not ready yet. Okay, all right, everyone is ready. So I'm going to ask you as audience members to give respect to the person who is speaking when the group leaders speak. It's not going to take very long, but it's an important step. So we're going to start with group 1 are going to read theirs out, and I'm going to be Adriana Exenades of a sort and write it on the whiteboard.
Okay, so we came up with lots of different ideas, but I think the 3 main ones that encompass most of the things we talked about. So number 1, attraction and retention. And this kind of combines in our number 2 as well, but we all know that there have been, especially recently, jobs advertised that have a lot of the carrot, so high-paying jobs to get doctors especially to come to rural areas, and that's obviously not working. So we were talking about individualising the package, so looking at the person who wants to come, so the specific person that wants to go to the specific area and why they want to go there and what will make it work for them, which rolls into our second point, which it doesn't need to be necessarily about the qualification, but it can be the skill set that the person brings to that town. So we were talking about looking at the primary healthcare model being divided amongst disciplines, so GPs, nurse practitioners, allied health, and looking at the skill set of the person that will fit the community or the area or the town. The third one that came up across, we've got people from quite a few different areas, was about coordination and sharing of information, and that seems to be a real issue in lots of remote communities about whether it's between hospitals and clinics or hospitals and hospitals or areas and areas, states and states, that being another major barrier in the way that adequate primary health care is provided to clients or patients or individuals. I think does that sum up our 3? Yeah.
Thank you, Group 1. That's a fabulous start. Now, can I have permission from the group to put in brackets, coordination, sharing of info? Is everyone okay if I write silos there? Silos? Okay. Although that does refer to funding too, so anyway. And services.
One of the things we talked about, and it came from Cheryl making a comment about not being funded for the administrative side of things, is if there could be a central coordination of money service delivery centrally, so not everyone was trying to do it, I think that could really be useful too. So that was a part of the coordination.
So I'm going to write up funding models as a topic. All right. Now, I know lots of you have got it, I heard you. So as you get up to read your 3, don't be offended if I don't write the topic up, because if it's already there, I won't write it again. I just might seek some clarification. Gus.
Thank you. With the Brains Trust around the table here. So we've got enormous amount of data behind, ideas behind this. So we've simplified it to staff and service. So we talked about skilled generalist workforce, we talk about building current capacity, coordination of services in town, locally, those sorts of words. Then we had community involvement and leadership, and we spoke about empowerment, capacity building, respecting uniqueness, those sorts of words. And then we also spoke about a remote primary healthcare model for all that again respects uniqueness, respects communities, talks about success measures, safety, quality, accountability, those sorts of things.
Thank you so much. That's excellent. Thank you, Group 2. Fantastic. Group 3.
I'll be a little bit briefer than all that, but we came up with community-driven solutions with a mutual understanding of from the community and services that are coming in about what people are wanting. So, people don't understand about where things are coming from and what services can supply different things. So that was a very important one for us. And we want minimum gold standards. There's so many models out there, and primary health care should be in every organisation, every remote area, every little remote town with having gold standards. So we need to make sure that, and there's a huge list that's there, so we need to make sure that the standards are there for everybody. And what's come up before is funding. So we need to know where the funding is coming from, that we get direct funding to these areas, and the government organisations don't have people coming in and sitting in their offices doing nothing, but that's because the funding's there, but people don't really want it. So we just got to make sure the funding's done properly.
Thank you. Excellent. Group 4.
Okay, the first thing that we brought up was for health professionals to have the resources needed to do the job. So to have the equipment that's needed, because that's to provide a minimum standard. So unless that's there, we're sort of half wasting our time. And it sometimes has to be tailored to a local area, etc. But it's incredibly important. Again, we're talking about funding too, so that the bureaucracy that we all deal with and the siloed funding, from discussions so far here the last couple of days, we'd all love to see everything being run from one place where we didn't have different levels of government fighting over who was responsible for what, and that the healthcare was actually the main objective. It wasn't to meet some budget requirements, depending on what department you're in. And we talked about obviously the selecting, like getting people to work out here, and we've talked about that, about selecting the right people before they start training, etc. But whether that's something that's already being done to a point, I'm not sure. But anyway, going back to that siloed funding is very important. That also technology was brought up. So there is equipment now that monitors your health, so blood pressures, etc., which could be available to everyone who's hasn't got a doctor that's immediately accessible. Now it's a cost for sure, but it would be so critical if whoever your health professional, whoever the doctor or whatever you're in discussion with through telehealth or whatever, if you've got a monitor on you which tells them immediately, and the technology's there, immediately what your signs are. So,
Sabina talked about that in her panel
Yep.
about having the equipment so that the on-the-ground people can do more. So, yeah, thank you.
and they may be expensive, but at the end of the day. And the last thing is, we often spend a lot of time talking about trying to get services that are never probably going to come here. So if we're talking about maternal or birthing centres, etc., you need an operating theatre. It just can't be done. Accept that. Don't keep fighting for it. But if you're going to have to go away, you know you're going to have to go away, meet the costs of that. And I know there is some funding now, but it doesn't meet the true costs. Accept where it's at, accept what has to be done, and meet the cost of going away to have your babies, for instance.
Thank you. Thanks, Stuart.
We've got the workforce recruitment and retention, but there was a lot of talk about the family-friendly policies with that. So we talk about things like accommodation being a huge issue, but also daycare, employment for partners, and travel was a big cost of travel, particularly looking at airfares, whether that's specialists coming in or family members travelling out, and having money available for the and when it comes to a patient needing to actually go to a Brisbane, Sydney, Melbourne, wherever it might be. The second one was a concept of a universal health obligation or a universal health guarantee, much like the telecommunications here in Australia. Many of you may not realise we actually operate under a universal service guarantee, and having something there that's to remote Australia. Some examples we've got, so how do you define what should be those standards? And it's a gold minimum, not a minimum. And it's things like, some examples we had were provider workforce ratios and guidelines, access to diagnostics, timeliness to care. I mean, the list could go on, but creating that base, but high quality. And our final one was collaboration, so particularly for RAM going forward. Once again, I'm operating that telecommunications space with NFF, and we're part of a group of RRCC, so that's Rural Remote Regional Communications. It's 21 different groups, so it includes flying doctors, CWA, farmer groups. We actually all come together with our own individual needs, but rather than duplicate, we actually go to government together, and we've been, over the last 7 years, we've been going particularly successful because we go to politicians, and as Susan said this morning, we'll go with 3 or 4 asks that everyone's agreed on.
Thank you. That's excellent. Group 6.
Our group came up with a little bit about communication as well, but we looked at that from RAM, developing like a charter, consensus statement, moving forward. We thought that was quite important to cohere the wealth of knowledge and experience that's in the room currently. Secondly, to promote the role of RAM in the marketplace to facilitate access for smaller remote communities. We talked about there being a number of conferences, and so moving forward from having a charter, I guess, a sub-element of that is to develop a communication model for RAM, so that we can access a broader stakeholder base. Does that make sense? We may need to have in RAM some access to synthesising data so that we can then lobby to get our stakeholders on board. And as we're promoting RAM as our issue, we're suggesting that we communicate what we're doing in the city as well as in the country to try to bridge the gap between that urban and the rural stakeholders. So in doing that, we'll pick up sub-models, and that will include the use of technology, which I think has been covered, and we spoke about technology, that there was quite a lot of technology in place but maybe not utilised. And our overarching conversation was working towards equitable universal care or gold standard care. Thank you.
Thank you so much. Interestingly, there was conversation about doing a Charleville charter post this conference to pull together the, well, as you just said so beautifully, Pam, the wealth of knowledge, expertise and the depth of conversation, so that that's part of the advocacy moving forward, is the Charleville Charter. That's the first stepping stone. So, oh, clever Pam. Sorry, next group. Yes.
Yes, that's us. So yeah, our table pretty much followed a lot of reoccurring trends topics, but our top three was bureaucracy. It pretty much affects all aspects and issues with health, and like, yeah. So that was that's okay. And silos, pool funding, you know, yeah, that's been brought up time and time again, which leads into the need for advocacy of misspending of remote funding, and finding remote funding as well. So really, like getting, you know, where is the money and how are we using it? But yeah, that was our top three.
Thank you so much. That's excellent. It's really nice that we're starting to get such replication, because it's showing that the topics that you think are important are very similar. Yes.
So I feel overcome by the wealth of knowledge in the room. That much higher level thinking is really lovely to hear. You know, because not everybody has that expertise, so I really appreciate that. On our table, access seems to come up a lot. So accessing health professionals in a timely and non-remote setting is just an ongoing problem. Thinking upstream from the problem, so encouraging communities and local governments to provide grants and incentives, so coming up with a community-based model and a more cooperative approach to the healthcare. So once again, dismantling those silos, I guess. And another thing is for RAM to facilitate some sort of survey nationally to find out probably what the grassroots problems are. And promoting RAM as a national group, so getting more people on board. I think that's us covered.
Fabulous. Thank you so much. So group 9. You can't refuse to share your outcomes. Judy's got the microphone. You wouldn't be game.
Hello. Ours have been very similar to a lot of other people's here, but our three top issues are, the first one is funding and resourcing, and that's how they make the silos. You're limited with what you can do. You can't give a holistic service, and a lot of places don't get any services in the rural remote areas. Number 2 is medical education to empower the patients and the training of staff. Education is a big issue because a lot of people in the bush don't know what services they can get to and what services that can assist them. And number 3 is the main one for RAMS, is issues to find solutions for these problems, be it lobbying, be it meeting with government, state, federal, local governments. But yeah, with the issues that we have from this, the consensus from here is a lot of issues are the same, is we need to find quality solutions for those issues.
Thank you so much. And Gillian, who didn't volunteer.
No, that's all right. We've had the benefit of being the last ones to speak and having the benefit of listening to everybody else's points. And we were very lucky in the fact that we only identified 3 consolidated ideas that we'd like to move forward with. The first and foremost is that we define a minimum standard of care with the continuity of primary care provider at its heart. That is the everything else must be centred around that continuity of a primary care provider. We think that is probably one of the most important aspects of community-led primary health care provision. Next is workforce, and underneath workforce comes a variety of issues that all tie into one thing: the funding, the trainees, creative recruitment, presence at events, how to make rural and remote areas appealing, and being more flexible in approaches to training and graduation. How do we address all of these barriers? And they all come under workforce. And finally, we'd like to see the reduction or the removal completely of the state border anomalies that make health education placements for doctors and specialists in remote areas so challenging and difficult to do, that make finding locums or being a locum so restrictive with the state-based rules that we have. And how do we develop a Commonwealth-funded approach to primary health care in the remote areas that makes service delivery effective, efficient and easy?
Fantastic. Thank you so much. Now, there is another group who've got they've got 3 top points. That's our online cohort, and they were super busy on their whiteboard. I didn't actually get to read any of it. So, Aaron, what did they come up with?
So I'm definitely not a health professional. I'm a surprise volunteer here. I helped the online group and did my very best, and I hope that I'm going to represent them well enough. But our 3 points were community-led health initiatives, invite professionals to volunteer out in the regions. I think one of the quotes from the online group was, invite a friend for a working holiday for a couple of weeks, and maybe bring professional development if there was a scope to bring that to the bush instead of having the doctors leave the communities to attend that professional development. And then linkages between professional bodies and remote organisations, which is basically what RAMS is doing, so that you have a consolidated community voice to go and lobby for you.
Thank you so much. So there's a really clear pattern that's come out of all of the work that you've done, that I'm now going to just do a bit of grouping together of some of these, because they actually can chunk up to be part of the same topic. And I'm going to put them on Mentimeter for you to all vote on what the groups should actually tackle this afternoon. So you're just going to have to give me a minute while I do that. And while I'm doing it, I'm going to hand over to Judy, because she's delighted about this. Is there any questions, clarification, anything that you'd like to talk about for 5 minutes? Lunch is 1, yes. We'll do lunch at 10 past. Okay, I'm handing over to you now, Jude.
Thank you, Wendy. Now, any talent in the room? Anyone happy to do a little floor dance, a little singing episode? But my dear friend, the chair's not here, so I actually get an opportunity to use the microphone. She's very good at taking the microphone away. So I haven't ever had an opportunity to say welcome from me and my family to everyone. My husband's family's been in the southwest, with our grandchildren being 6 generations. We live 140 kilometres from here, on the headwaters of the Paru River. And I've got a 6-year-old and a 4-year-old grandson. And this is why I'm still an advocate, very passionate. I'm a registered nurse, and I'm here making a difference for my family. So I'm delighted to see that we've pretty much got a cross-section of Australia, and how lucky are we, and how sad for those out of 600 invitations didn't care to join us for this day and a half in Charleville. I must apologise for the flies, but welcome to remote Australia. Well, it's not the afternoon mim just yet. So can I take any questions? Is there anything you would like to share with the room while Wendy's busy? Happy to do a bit of roving mic. While Annabelle's not available, she's back. While I've still got the mic. Yes, and yes, Nan.
Where did the idea of Remote Australians Matter come from?
Annabelle. It was very short-lived.
What was the question?
Where did the idea of Remote Australians Matter?
Oh, golly. We got anything else to do for the rest of the afternoon? How long have I got? Okay. In all seriousness, it involves quite a few people in this room. What was the question? Sorry. No, sorry. Okay. The idea evolved over probably the last 8 years, since I wrote a book called Bush Doctors, and when I was researching it, I saw a segment of Backroads that Heather Hewitt, as some of you would know, narrates, and learned about Dr. Sarah Renwick-Lau at Malakuta, and I thought she needs to be in this book. At the same time, I actually, because I was writing about the book, I learned about the Australian College of Rural and Remote Medicine in 2017 when the book came out. Marita Cowie, who's the CEO of ACRM, invited me to bring the books to Melbourne for the ACRM conference. And so I learned a bit more about ACRM. I met Sarah, I met Stan, I met Robin Bryant, who's another of our directors. And I then, as I said, learned a bit about ACRM. So a year later, when they actually advertised for a community director, for their first community director, I successfully applied. I had absolutely no qualifications other than the fact that I was very much a rural, remote Australian community person. You can teach governance, apparently, and you can teach someone to read a financial sheet, etc., but you actually can't teach what it's like to live in a remote area if you don't live there. And that's what ACRM embraced right from the get-go. So in the course of that, because they could see the value of a community reference group, we started a community reference group. Gus, White, Judy and Stan are all members of that community reference group. And we've been talking, as I said, over all of this time about all of these issues that impact on rural and remote Australia. But we were all really concerned about the issues in relation to remote Australia because it gets overlooked in the whole context of rural health. So we decided to do something about it. We stepped away from the college because, well, for starters, if we fell flat on our face, we didn't want it to reflect on the college, but more to the point, this is very much a community-driven initiative, and we believe very strongly that if we're going to make change, community has to drive it. Clearly, the other way has not worked successfully. So if all of you and all of your friends and everybody you know in remote Australia can get involved with this organisation, then I think, and we work together. This is about everybody who lives in remote and very remote Australia, regardless of who they are, how they came to be here, whether they're in a mining community, a tiny town, on a cattle station, an Aboriginal community, in a fishing village, on a boat, on an island. Do you all realise that Norfolk Island, Kangaroo Island and Christmas Island are all part of MMM7, which is remote Australia? So this is about everybody who lives in remote Australia and trying to help them not only access better health outcomes, but to actually play a role in making that happen. Does that answer the question in 3 minutes?
Thank you, Annabelle. Short and sweet, as usual. So, following on from Annabelle's story of how RAM has evolved, would anyone like to ask a question? Fabulous. Yes?
I get to hold it. I feel very special. Slight background about me. I'm based in Toowoomba now, but I'm originally a Charleville local. I don't come from the health space. I'm actually a solicitor and I work around older people and domestic and family violence. So a different kind of a link in, but very important within the health space. When I guess I'm looking around the room and we're talking about RAM and the really important, wonderful things that have come out of here, how are we ensuring that RAM has a diverse voice? We are in quite a remote place that we've travelled from. We've got obviously a barrier of money in attending this function in the first place. How are we ensuring that when we have under-resourced places that are outside in the community, that we're providing some type of subsidisation to ensure that there's more diverse voices that are coming across? I know we've got the online session, but how do we get those people here? How are we making sure that across this room, and perhaps when I'm looking out across the room, I am seeing maybe a bit of a sameness in some ways, or an older skewing towards people, or if we look at, if we're here, we probably have a job that lets us be here. We probably have the funds and resources, or we work for a place that's let us have time off work to attend. How are we getting those other voices to attend and put their, I guess, views forward within what we're sharing, what we want to do in terms of lobbying?
Thank you, Alana. Something we were going to share with you when we come back in after lunch is when you move into your next groups of 20, we will be asking you to identify someone who would like to nominate to join us a committee below the directors of RAM. The directors of RAM will then review the nominations, and you may nominate yourself, or you may tap someone on the shoulder and say, Gus, I've seen you perform at conference. You've got some good ideas. I like your style, even if you're from down south. We'd like you to think about nominating. So we are developing, we want to broaden our group, Alana. We also wish to start, as of today, developing succession, because our age group will run out of steam. It's your age group that will continue to drive RAM. Have I helped answer your question? Thank you. Over to Gus.
Even if I'm from South. Just adding to that, RAM, I guess our attitude would never be that we unfortunately could represent everyone in remote Australia. We would, however, we do, however, take the attitude that we would love to hear as many perspectives as we can. And so the more perspectives that we can have and build on, the better the story and the more robust and more diverse, and we can make sure everyone is part of it. So that we just encourage everyone to bring their stories to RAM so that we can go with a really well thought out perspective that's diverse, that accounts for as many stories as it can.
Thank you, Gus, and I think Wendy might be ready if there's no other questions. Thank you.
Can I please have my computer connected to the screen? So here's the exciting bit. It is like the Logies. For the second time, you're going to get to vote. Oh gosh, I think you're going to get to vote on which topics you want the groups to work on this afternoon. So it's the Mentimeter code on your table. There's a code at the top. You've got to scan it on your phone. And someone's been in there. It's a bit hard to see on the screen, but with this one, you touch on every option and then you drag them or click them up and down in the order that you want them. It'll make sense when you get in there, I promise, but you've just got to touch on... So the reason why it gets you to touch on the options is you don't have to rank every option. If there's only 2 topics you think we should be looking at, tap those 2. If you want to rank all 10, rank all 10. So if you're online, there's a code at the top of the screen that you can use to go into your Mentimeter SIM. You can't scan the code, or they may have been sent it. I did ask. So I hope that's making sense. So if you tap on them, you can rank all 10 in order from 1 to 10 if you want, but if you only want to do 3, do 3. But there's 10 there, you can vote however you like. If you have any questions, pop your hand up and I'll scoot down and talk to you. Charter is on there. The charter is universal health. Oh, it fits in under the universal health obligation, I thought. Oh, this is so exciting. It's like watching the TV on election night. That is exciting. So we're having our own election party here. I'll give our politicians PTSD talking about it. So, coming in first at the moment, because I realise you won't be able to read them very easily, community involvement and leadership, followed by the universal health obligation, followed by workforce, followed by place-based community primary healthcare models, followed by funding and resourcing, and we had silos there. Service standards KPIs 6th, bureaucracy 7th, continuity of PHC provider 8th, resources, equipment and technology 9th, and information silos is 10th. So information silos potentially could wrap up into the model of care as well. I just realised, but... So hands, I guess, is there anyone who hasn't finished yet? There is no rush. It says 78 people have done it, so that's not quite everyone. So we are able to go out to lunch now. Let me just... Our time is a little bit different to what we thought, but we're only running 10 minutes late, so that is excellent. I think we will still return at 2 p.m. And when we come back in at 2 p.m, we're going to be divided back into the 10 groups, but we're only working on 5 topics. So that'll be the 5 topics that win here. So please go to lunch, enjoy lunch, chase those people you haven't asked questions to or met yet, and come back in to the funky tunes and dancing, all energised, at 2 p.m. Thanks, everyone.
Falling too fast to prepare for this. Tripping in the world could be dangerous. Everybody circling as vultures. Negative, nepotist. Everybody waiting for the fall of man. Everybody praying for the end of times. Everybody hoping they could be the one. I was born to run, I was born for this. Whip, run me like a racehorse. Pull me like a ripcord. Break me down and build me up. I wanna be the slip. Word upon your lip. Rather that you rip. Break me down and build me up. Whatever it takes. Hanging on to the visual, I wanna be invisible. Looking at my years like I'm out of dumb. Everybody needs to be a part of them. Never be enough on the prodigal son. I was born to run, I was born for this. Whip, run me like a racehorse. Pull me like a ripcord. Break me down and build me up. I wanna be the slip. Word upon your lip. Rather that you rip. Break me down and build me up. Whatever it takes. Cause I love the adrenaline in my veins. I do whatever it takes. Cause I love how it feels when I break the chains. Whatever it takes. Yeah, take me to the top. I'm ready for whatever it takes. Cause I love the adrenaline in my veins. I do what it takes. Critical, egotistical. Don't wanna be the parenthetical, hypothetical. Working onto something that I'm proud of. Out of the box, an epoxy to the world and the vision we've lost. I'm an apostrophe. I'm just a symbol to remind you that there's more to see. I'm just a product of the system of catastrophe, and yet a masterpiece. And yet I'm half diseased, and when I am deceased, at least I go down to the grave and die happily. Leave the body of my soul to be a part of me. I do what it takes. Whatever it takes. Cause I love the adrenaline in my veins. I do whatever it takes. Cause I love how it feels when I break the chains. Whatever it takes. Yeah, take me to the top. I'm ready for whatever it takes. Cause I love the adrenaline in my veins. I do what it takes. said, don't give up. It's a little complicated, all tied up, no more love, and I'd hate to see you waiting. Had to have high hopes for a living, shooting for the stars, but I couldn't make a killing. Didn't have a dime, but I always had a vision, always had high hopes. Had to have high hopes for a living, didn't know how, but I always had a feeling I was gonna be that one in a million. Always had high hopes. Mama said, something for oddities, stranger crusades. Ain't ever wanna be the winning the novelties that don't ever change. We wanted everything, wanted everything. Stay up on that rise, stay up on that rise, never come down. Oh, stay up on that rise, stay up on that rise, never come down. Mama said, don't give up. It's a little complicated, all tied up, no more love, and I'd hate to see you waiting. They say it's all been done, but they haven't seen the best of me. So I got one more run